We'll start, sir. Pramod, sir.
Yes, definitely, sir.
Okay. All the speakers and panelists are ready.
Yeah.
Welcome, friends and my colleagues, to the 7th webinar of MCNS. Today's topic is can can you can I get the screen sharing?
Screen.
Okay. Sorry. Madam, please close your screen sharing.
Okay.
I will just my slide.
Yes.
My single slide. So we have got the eminent speakers and panelists for today's webinar. And today's webinar will be moderated by Dr. Pramod Giri. He is Director of the Neurocritical Care at Nagpur. And he is also member of the Board of Education of Neurological Society of India. And we have the speakers, Dr. Rajeshri Dev Pujari. Ma'am doesn't need any more introduction. She is Additional Director of the Department of Anesthesia, Jaslok Hospital and Research Center, Mumbai. And she will be talking about airway ventilation and sedation in acute neurocare. Our second speaker is Dr. Ravindra Ghawat. He is Director at Critical Care Jupiter Hospital, Thane West, and he is affiliated to Indian Society of Critical Care Medicine. And he will be talking about ventriculitis and meningitis management. Our third speaker is Sushant Admane. Dr. Sushant Admane, he is Chief Intensivist and Clinical Director of Neuron Brain Spine Critical Care Center, Nagpur. We have got the three eminent panelists. Dr. Pradyumna Oak, he is Director Department of Neurology at Nanot Hospital, Mumbai. We have the second panelist, Dr. Kishore Chaudhary. He is from Sheffield, UK. And we have the third panelist, Dr. Nikhil Balankhe, Director at Critical Care Department of Critical Care Medicine, Viveka Hospital, Nagpur. With this short introduction, I would like to have some appeals to the members of MCNS. In the month of November, we are going to have the third newsletter of MCNS time. So I request all the members to send their articles to the editor, Dr. Sudhir Ambekar. And our conference is coming in very short time at Nagpur in the 23rd to 25th February. And the early bird registration date is also coming to close in within few days. I request all the members to register earliest and take the benefit of early bird registration. And with this short introduction, I hand over to Dr. Pramod Giri to carry on this webinar. Thank you, sir.
Thank you, Dr. Milin. Hello, Dr.
Hello.
Nikhil. Yeah. Hi, sir. Dr. Nikhil. Hello, you are mute, I think. You are mute.
Yes, I'll just unmute myself.
So now
Yes.
we just started with the small introduction by our secretary, Dr. Milin Dulake, sir. And now we will be coming towards the main part. The first talk is the presentation of Dr. Rajeshri Dev Pujari, ma'am. She is going to tell us about emergency in neurocritical care. It's such a difficult topic, and she's going to cover in such a small time. But let's hope that we will get that all the twilights of our whatever she is having of her all the experience. So let's hope that we will be enjoying this. Yeah, ma'am, hand over to you, ma'am.
Thank you. Thank you. Thank you very much, Dr. Pramod, Dr. Milind Dunake, and the MCNS for continuing with Neurocritical Care Part 2. And I am trying to take a very long topic, but a very important topic in a small way. So in the next few minutes, it will be protocolized, and I would like to give you a algorithm of how to go about it. So airway management and ventilation are central to resuscitation of the neurological ill patient. We have seen that often evolving processes threaten the airway and can give rise to inadequate ventilation. Furthermore, all the manipulations which we do, that is intubation, ventilation, and sedative choices, directly affect the brain perfusion. So in the next few minutes, let us see that we keep the brain intact and do not make the primary injury in the brain go into the secondary phase. And for that, airway management, we have to have some objectives which we should learn. We have to find out whom to intubate, when to intubate, how to ventilate, and how to sedate. Our goal is to maintain adequate oxygenation and ventilation, avoid excessive or less ventilation, and mainly to prevent aspiration. So it is important prior to sedation or muscle paralysis that you do a rapid detailed neurological assessment and documentation. So it provides us the functional baseline for further assessment. Now, whom to intubate? Those patients who come as a neurologically ill patient, you can almost understand when to intubate if they are in a respiratory arrest or an impending respiratory arrest, hemodynamically unstable, and as all of us have been taught that less than 8 GCS, you should intubate and ventilate. And the most important thing is those who cannot protect the airway. So when do we intubate these patients? Some of them may be intact, but when you find that there's failure to oxygenate, there is cyanosis, SpO2 is dropping, and if you have the ABG, you see the acidosis. And if there is tachypnea, there is excessive work of breathing, end-tidal CO2 goes up, there is risk of aspiration, and you anticipate a declining course in these patients, you need to intubate. How to intubate? First, assess for the airway. Most important is to assess for the bag mask ventilation and intubation. Find out whether it is easy or difficult. Then, along while you are assessing, start planning and preparation for assistance and equipments. You have to administer some drugs for induction or and also at this time start with pre-oxygenation and provide for apneic oxygenation when you give muscle relaxants. Also, maneuvers of the airway can give rise to increased sympathetic drive, and which can increase the ICP where in these particular patients. So specific precautions which you take is in head injury, unless ruled out, always keep in mind about spinal injury or cervical trauma. Also take care of those people who come with neuromuscular weakness and raised ICP. All patients who come as neurological patients, many of them have a raised ICP. So as a rule of thumb, just consider that everyone has a raised ICP without default. So a neurological baseline assessment is done, consciousness is found out, cranial nerves, pupils, corneal reflex, etc. are found out. Cortical functions, visual fields and gaze is seen, language, verbal function is assessed, motor function is assessed, seizure, if it is present or absent, can be assessed, and tremor may sort of look like seizure, but that is something which you have to do very fast. And cervical spine, find out the mechanism of injury, see the pain, tenderness, stability, and if there is some disability, find out the sensory level. So the main indication, and we need to intubate these patients, and we have already done the detailed neurological examination, and we have identified the injury. See, if you feel that the cervical spine is clear, abolish unnecessary intervention. The main indication for intubation followed by mechanical ventilation in acute brain injury are respiratory insufficiency, secondary to seizure, lung injury to trauma, ARDS, neurogenic pulmonary edema, or hemodynamic instability. And of course, depressed brainstem reflexes, leading to loss of protective airway reflex. And as an adjunct, you can use intubation as an adjunct to reduce raised ICP. Important for us now to assess the airway after this. So you have to assess the airway for the bag mask ventilation and for intubation. And there are nice mnemonics which can tell you, say lemon, which will predict difficult airway. L is look, E is evaluate mouth opening and airway position. We'll go into it later. Malampati score is also used very, very commonly by everyone. And obstruction in the neck or the neck mobility is used. I cannot go into details about that, but most of you can find out all these mnemonics with the help of your anesthesia friends. So predict bag mask ventilation. Bag mask ventilation is very important when you do apneic, when the patient goes into apnea after paralysis. And you should not have hypoxia at that time or unable to ventilate this patient, and then you go into very critical steps as where you cannot ventilate, cannot intubate. So again, it has a mnemonic, that is, you see the mask seal, see obesity, age more than 5, edentulous patient, or with stiff lungs. So what is important is this difficulty should be anticipated. And you prepare for backup, call for help, keep a difficult airway cart, drugs, equipments, LMAs, video laryngoscope nowadays, bougies, stillets, cricothyrotomy sets, etc. So as you see in this picture, this is a picture of a patient which I've done a few weeks ago. And obviously my resident said, Madam, it's not going to be very difficult. This is absolutely, it was a difficult picture. And my resident had forgotten to do the evaluation of 3/3-2 rule. Now you have to understand that the E of the lemon means evaluation, very, very important. See if this mouth opening is adequate. Will 3 fingers of the patient fit between the incisors? And if not, mouth opening may be limited to permit adequate laryngoscopal visualization or manipulation of the endotracheal tube. Will 3 of the patient's fingers fit between the chin, the mentum, and the hyoid bone? If not, the airway may be too anterior for easy visualization. Will 2 fingers of the patient fit between the hyoid and the superior thyroid notch? If not, the airway may be too high in the neck for intubation. So during intubation, what is most important is you do pre-oxygenation with 100% O2 while you're preparing for all this. Now, there is HNFC, which is available nowadays called Thrive, but maybe not available. But of course, 15 liters of oxygen by plain mask or even nasal prongs is preferable while you're doing all this. Now, the preferred method for these patients is a rapid sequence intubation. So we administer drugs. In the pre-induction, you can administer lignocaine, fentanyl, esmolol. This blunts the RSR and rise in ICP. Induction, you can use etomidate or ketamine, depending on the hemodynamic state of the patient. And muscle paralysis, you can, in RSI, you usually use SUX, but if there is a contraindication, suxamethonium, rocuronium is a good drug. Bag mask ventilation should be done with low volume during apnea, and laryngoscopy and intubation should be rapid. Why? The main thing is maintain brain perfusion pressure. That is CPP and oxygenation. This is important. This is a goal which we have set. So CPP is mean arterial pressure minus ICP. ICP should, in a normal patient, should be less than 20. So mean arterial pressure should be at least 80 to 110 to target a CPP of at least 60. But as I said, ICP will be raised. So mean arterial pressure should be on the higher side. Now, what happens is most of these patients have signs of raised ICP, headache, vomiting, etc. So intubation and maneuvers may increase the ICP, and induction agents may decrease the mean arterial pressure. So therefore, your technique and selection of drugs is very important to keep a balance. So airway manipulation, there are two ways in which you can get a raised in the heart rate, BP and ICP. This is called as a reflex sympathetic response. And this is even when you are just moving your head or head tilt, chin lift or whatever, or if there's a spine, you do not do a head tilt, you just do a jaw thrust. This also maneuver can raise the ICP. And if you put it, as soon as you put in the laryngeal, your laryngoscope, there is a direct laryngeal reflex which gives rise to raised ICP. So you have to mitigate elevations in the ICP by minimizing airway manipulation and administering, most important, is pre-medications. So pre-medication of choice is lidocaine. If you can give 1 milligram to 1.5 milligram per IV, it blunts the ICP response. Fentanyl is another drug of choice, 1 to 2 micrograms, though it is 2 to 3, it is written. And it again blunts the ICP raised. Esmolol can be used, but esmolol will have a very short timing and may not help us in when you're doing the laryngoscopy itself by itself. So induction, now after induction agents which we are doing is etomidate, propofol, ketamine mainly. So etomidate would be a good drug of choice. Unfortunately, it decreases the Schizer threshold, decreases the CBF, however, maintains the in larger doses only. It has a tendency to decrease the cortical synthesis, so you avoid in sepsis, but it is found to be a good drug of choice, and usually we use it. Propofol by itself can give rise to sedation, reduces the ICP and airway resistance. However, hypotension can offset its action and the patient can have a low blood pressure, which we don't want. Ketamine by itself is also a good induction agent. It can give analgesia, sedation, amnesia, and it can raise the ICP, but it is good in hypotension. It has a bronchodilator effect, and if not treated with benzodiazepine, can have reemergence. Thiopentone is probably not used nowadays because of its hypotension and bronchospasm. So paralyzing agent, as I said, succinylcholine, unless proved otherwise, it is contraindicated in neuropathy, malignant hypothermia, hyperkalemia, myopathy, and sometimes it should not be used if the injury is more than 24 hours. And rocuronium is the drug of choice. So intubation, how would you do an intubation? So if you are suspecting raised ICP, lower the head for briefly only for intubation. Prevent the fall in MEPs, adequate analgesia and sedation, which you should do, and adequate pre-oxygenation. Avoid hypoventilation because this increases the PaCO2 and it will increase the ICP. So you have to monitor end-tidal CO2 while you're doing intubation as well, if you can. Protect the spine in trauma. And if there is brain ischemia, which happens in ischemic stroke, vasospasm, etc., the ischemic area and the penumbrum area has got a collateral supply from the normal region. So you avoid vasodilator drugs, which will divert the flow away and avoid hypotension. And as we have seen, in even episodic hypotension for a small amount of time can give rise to poor outcome. Avoid hyperventilation, maintain normocapnia and normotension. In suspected spine injury, please do the manual inline spinal stabilization. Do not use cricoid pressure, and video laryngoscopy can help, though fiber optic intubation is preferred if it is present. Remember, if you want to do fiber optic intubation, see that the patient is awake, spontaneously breathing, and cooperative, and that whoever is doing the fiber optic intubation has done it before and is not doing it first time. So post-intubation, confirm the tube position, secure end-tidal ETT, chest rise, auscultation, waveform, capnography. Maintenance of ventilation is respiratory and hemodynamics, hemostasis. Goal, of course, is normalize oxygenation with the lowest FiO2. That is inhaled oxygen tension. That is, keep the SpO2 slightly above 94. Normalize ventilation with ABG gases. See that PCO2 is not more than 30, 45. And end-tidal CO2, which we can easily monitor, is 30 to 40. Normalize the work of breathing and prevent ventilator-associated injury. So keep, most of the times, the first thing we do is, the mode is volume controlled ventilation, where we keep the tidal volume 8 ml or less, or 7 to 8 ml, and the respiratory cycle 12 to 14. These are titrated to maintain normal PCO2, except in chronic hypercarbia like COPD. In chronic hypercarbia, admission bicarbonate levels are used to estimate the baseline PCO2 which you want to target. So oxygenation, remember that keep 100% oxygenation only for pre-oxygenation. Please, then the lowest FiO2 to maintain saturation of 95 to 100 should be used. Try and keep the FiO2 0.5 to 0.6 and monitor oxygen by pulse oximeter. In ventilation, there are special areas where you need to change the ventilation, like in brain herniation. The patient is herniating. You want to maximize the cerebral vasoconstriction by achieving a PCO2 of hypocapnia. And you see that PCO2 will rapidly give rise to cerebral vasoconstriction and give rise to decrease in the ICP. But below 20, it is ineffective, and it may impede the venous return, decrease the BP, and offset whatever advantage you have by giving rise to cerebral hypoperfusion. Hyperventilation for ICP is not safe or effective for a prolonged time. It can be a temporary measure to prevent herniation. And once treatment is instituted, hyperventilation should be rapidly weaned off. So we see that in acute brain injury, there is a trigger for the SIRS, that is sympathetic stimulation, because sympathetic inflammatory response syndrome with cytokine release. They can also damage the alveolar capillary, lung injury, giving rise to less amount of PCO2, increased PCO2, less PO2, and thus compound the acute brain injury. Not only that, if the ventilator is not taken care of, ventilator-associated injury like barotrauma, volume trauma, high FiO2 can compound again whatever you're doing. So in these cases, it's important to have a lung protective ventilation strategies. That is low tidal volume, 6 ml per kg, low pressure, at plateau pressure, less than 30 millimeters of mercury, use of PEEP, and FiO2, as I said, is less than 0.6. Now, PEEP has a potential to transmit to the intrathoracic vessels and increase the ICP, as we have seen earlier. But sometimes PEEP is well tolerated in brain-injured patients, and the lung compliance is poor, and we should utilize this phenomena. And also see that it is reviewed individually and personalized PEEP if you want to. Then coming to the third part of the we have to take in consideration, now we have put the patient on a ventilation, we have to worry about sedation. Now, what is sedation? Sedation is necessary yet undesirable. So it is paradoxical. Why is it necessary? But sedation can also go haywire if it is not done properly. So it is necessary to alleviate fear, anxiety, agitation, and reduce ventilator dysynchrony. It reduces the ICP and also reduces cerebral oxygen consumption. It is, of course, helps in facilitation of intubation and the patient is able to tolerate mechanical ventilation better and reduce the reflex sympathetic nervous activity, especially seen in traumatic brain injury or in many cases. Now, why is it undesirable? It makes acute neurological examination difficult or impossible. It can cause vasodilatation, leading to hypertension, which we don't want, and prolonged sedation can worsen cognitive outcome and contribute to muscle weakness. So decisions regarding the need for craniotomy, endovascular therapy, ventricular drainage, ICP monitoring, etc., and other life-saving therapies require an accurate neurological assessment. At the same time, the patient should not be agitated, uncomfortable, severely hypertensive, or safe. So need of sedation must be weighed against the need for accurate neurological assessment, and it should be tailored personally. So the drugs for sedations most commonly used propofol, fentanyl, benzodiazepine, dexmedetomidine, and barbiturates are there. Barbiturate is probably not used unless you need burst suppression. So let's come to the drugs, and each drug by itself, everyone must have used it, has its own pros and cons. Propofol loading dose, though it is 5 microgram per kg over 5 minutes, can be reduced in an Indian population. Onset of action is 1 to 2 minutes, and it can give rise to hypotension and propofol infusion syndrome. And as we said, we have to balance the hypotension, so we do not want too much of hypotension. And the other thing is propofol can be used for patients with status who need a burst suppression, and that's a good drug where we can be used. The dreaded complication is propofol infusion syndrome, so many ICU people do not want it for prolonged time. Dexmedetomidine is another very good drug. The adverse effect of hypertension and bradycardia is probably overestimated. It's not that bad. It's one of the most gentle drugs which can give rise to not only sedation, but the patient can maintain the airway and be awake as well to responses. And also, there is some amount of analgesia. Midazolam is a favorite drug, and the unfortunate part of it is active metabolites may accumulate in renal failure, and you can get prolonged action of midazolam. Morphine, somehow we have not used in our ICU, but fentanyl is very, very useful, and the bolus does, it's used along with midazolam many times, giving a very good effect in the ICU, and it has a short context life, and it can be easily reversed. The only adverse effect is chest wall rigidity following a bolus. So give midazolam not as a bolus, but as maintenance. So now we have sedated the patient. How are we going to find out if your sedation is good or not? So there are many scales. One of the two scales which I will describe today is the behavioral pain scale. So, the score should not be greater than 5, which represents severe pain. The other one is the RASS, or Richmond Agitation Sedation Scale, and this is very good because it will tell you whether the patient is agitation or sedation, and try to get into lightly sedated, -1 or -2. So in conclusion, I would just want to give you an algorithm, and which says airway ventilation sedation. Have you find out if you want to intubate the patient. If you want to intubate the patient, document the focused neurological assessment, and also assess difficult bag mask ventilation. Assess for difficult intubation. If difficult airway is anticipated, please call for help. See that the most experienced provider to the bedside is there. Confirm resources to establish emergency surgical airway. Yes, the LMAs or the second generation airways or LMAs are very, very good and very helpful many times. And there's a big, huge algorithm for difficult airway in which it can be used. So airway adjuncts are very good and very useful, and have become better and better as the days have passed, and very inexperienced people can use these airways. The other thing is the video laryngoscopy, which has made it very, much more easier on the bedside, and the learning curve is not very high. So the other is a special consideration during intubation would be apneic oxygenation. Use the appropriate induction agents, cervical spine precautions, and anticipate and treat IRAs in ICP to maintain adequate cerebral perfusion, avoid dysoxia and ventilation. Do a post-intubation checklist, do the SpO2 end-tidal monitoring, secure, confirm the tube position, and then go into ventilation. Ventilation target SpO2 94%, target pre-morbid CO2 as I told you, target the pH at 7.3 to 7.4. Use hyperventilation only for herniation syndromes and prevent lung injury by lung protective strategies, which I've discussed, and keep the normal work of breathing, assess ventilator patient dyschrony. And sedation is titrate to light sedation, that is RASS is 0 to 0.2. Consider analgesia-based sedation. Consider intermittent sedation. Give a sedation holiday, and X and propofol can be used when you need to continue. Deep sedation may be necessary for ICP control and seizure management for use of neuromuscular blockade. Sedation interruption, unless contraindicated, exists. So this is all I think about it. I have probably overstepped for a few minutes, but thank you very much.
Thank you. Thank you, Rajshri Madam. It's an excellent talk. I think that every aspect of the ventilation, sedation, elective ventilation, emergency ventilation, to reduce down the intracranial pressure, you are given lights, you are thrown everywhere on the every small aspects of ventilation, respiration, and sedation. Yeah, many a times it is there is a lot many difficulties in putting the patients on sedation. So what to do, how to take it as a light sedation mode. And so we are really thankful. We will take the questions after the all the three talks. We are running short of time. So next speaker.
I'm sorry.
No, it's okay, ma'am. Despite of your ill health, you have taken out the time. Thank you, ma'am. Second speaker is Dr. Ravindra Ghawat. He is a Director Intensive Care, Jupiter Hospital, Thane. He is going to speak us, tell us about the ventriculitis and the meningitis management, a difficult topic. Dr. Ravindra.
Thank you. Thank you, Dr. Pramod. I hope I am audible to all.
Yeah.
We'll start.
Absolutely, Ravindra, share the screen.
So the topic given to me is ventriculitis and meningitis, and I am going to predominantly talk on hospital-acquired or nosocomial meningitis, not the community-acquired meningitis. So, sorry. So, ventriculitis and meningitis we commonly encounter, and usually from the community, if you get ventriculitis, it is secondary to meningitis, bacterial or viral infection, and then secondary bacterial infection sometimes. Sometimes the cerebral abscesses can rupture into the intraventricular space, and then you have ventriculitis. But the more common or more commonly seen ventriculitis is when you have an indwelling catheter, and which is usually nosocomial or hospital acquired, when you have a shunt or an EVD, a patient who has a traumatic brain injury and an open fracture, or a cerebrospinal fluid leak post-surgery or even after trauma. It can be as a complication of a neurosurgery or a complication of an intrathecal chemotherapy, which has been routinely used nowadays. Are we really worried about this problem, and why does it worries us, and what makes things hard about this problem? Just because the mortality in these conditions is very high, that is 37%, which is a very high mortality in this era. And what has been found is that 93% of the patients had some predisposing factor when they had nosocomial meningitis, which is in terms of traumatic brain injury or Bezier curve fracture or a brain hemorrhage or a device. And it was predominantly device which was responsible for it. Only 7.1% had patients who had an systemic bacteremia and then endocarditis or a dental abscess and then had secondary meningitis and ventriculitis in this particular data. And most of the time, whenever we have this nosocomial meningitis or ventriculitis, I will use the term VM here in the further slides or further discussions. It is gram-negative bacilli, and sometimes it is gram-positive. We'll come to that later. Now, the other thing is there are many challenges when we think about diagnosing this ventricular meningitis or ventriculitis meningitis, because patients are usually sick, they are on ventilator, they have a low GCS, so it becomes very difficult to categorize whether this is meningitis which has caused a problem or this is something else. Where is the infection? Is it from the brain or it is from somewhere else? Like these patients might have ventilator associated pneumonia, they might get seizures sometimes, they might have a catheter related bloodstream infection, they can have many metabolic factors which can actually complicate matters, they might have hyponatremia and so on. And the symptoms may not be very overt, they might be all subtle, and you need a very high degree of suspicion to actually diagnose them. The other thing is that the classical signs of or findings in CSF may not be evident. Sometimes, the elevated cell count, the decreased glucose and protein, high proteins that you usually get, they may not be reliable. Vice versa is also true that sometimes your normal CSF doesn't rule out an infection, whereas a high CSF count, high cell count, or a low glucose or a high protein count may make an intracranial hemorrhage as well, and aseptic meningitis as well. So only a positive CSF culture supports the diagnosis. So with those challenges, it is really difficult to diagnose it. But do we have something on cards? Yes, we have something by CDC, which gives us some definition, some insight into how we can diagnose it. If we find an organism cultured from the CSF, that definitely diagnoses with a suspicion of meningitis ventriculitis. That definitely tells us this is meningitis or ventriculitis. And apart from that, at least two of the following symptoms like fever, headache, or pharyngeal signs or cranial signs in patients who are more than 1 year of age, or at least one of the following like increased white cell elevated proteins or glucose in CSF that we classically see in meningitis or ventriculitis. Organism seen on the gram stain or CSF, as I said, or organism cultured from blood with these signs, one of these signs, or a positive non-culture of PCR-based test or something like procazinol lactate, which is indirectly telling you from the CSF or blood or urine, which will lead you to the diagnosis, or a single antibody titer also can help you in diagnosis. So apart from this, there are other symptoms that and signs that we can look at is nausea, lethargy, seizures. New onset seizure can be a sign of ventriculitis, a worsening or sudden change in mental status. Apart from that, some signs like erythema and tenderness, or a subcutaneous shunt, or a EVD which you have put, or a subcutaneous shunt. Signs of peritonitis if it is a ventriculoperitoneal shunt, or signs of pleuritis if it is a ventriculopleural shunt, or sometimes glomerulonephritis with hematuria if it is a ventriculoatrial shunt. And if there is no other etiology which can explain this, we can definitely suspect or think about the ventriculitis or CNS infection. The other thing that helps is if you have a drain, or if you have some procedure which is done on the brain, neurosurgical procedures or trauma, usually after 5 to 7 days is a period which has been found where you would develop the signs and symptoms, and it is not within 48 hours where you can actually think about the infection. Coming to the diagnosis, blood, of course, you will look for increase in the WBC count, sometimes decrease in the platelets. You will send a blood culture. If the blood culture is positive with suspicion and signs of meningitis, then probably this is the organism or this is the infection. If there are no other indwellers, that will help you further. Then CSF, classical findings of increased proteins, decreased glucose, and the increased WBC counts with increase in the polymorphonuclear cells. To differentiate from intracranial hemorrhage, nowadays people are also using a cell index, a ratio of WBC to RBC in the CSF divided by the ratio of WBC to RBC in the blood. And it is assumed that it should be similar because intraventricular hemorrhage, if it is intraventricular hemorrhage, it should be similar as it is in the blood. So any deviation would make you think that, okay, this is probably an infection and not intracranial hemorrhages. So cell index is coming up, though its validity is still under study. The other thing is lactates. You can look at lactates in the blood as well as CSF, and neuroimaging would predominantly help us in differentiating the diagnosis rather than leading to the diagnosis. These were the usual findings. These are from the CDC. What the blood panel had shown in many of the patients: increase in the WBC count with polymorphonuclear leukocytosis, increase in CRP, sometimes increase in procalcitonin, sometimes it may be normal. Then in the CSF analysis, as we discussed, decreased protein, increased proteins, decreased glucose, increase in WBC cells with polymorphonucleocytosis. Now, apart from that, can we do any other test in the CSF which will help us in the diagnosis? Because as I said, that it is not forthcoming the signs and symptoms, and many a times the diagnosis may not be clear. So what you can do is you can do a CSF lactate level. If the level are more than 4, that points towards an infection in the meninges or the ventricles. Elevated CSF procalcitonin level, you can look at the procalcitonin like you do for the blood. You can also look at the procalcitonin in the blood as well as the CSF. Then there are certain biofires or nucleic acid amplification tests or PCR based tests from the CSF that can be done, and those will tell us about the organisms. In an advanced setting, we can also send some specific like 16S RNA PCR test, which will give you a diagnosis, but it takes time of around 2 weeks. Hello. If you have a suspicion of fungal infection, you can also look galactomannan and beta-D glucan levels from the CSF as well as blood. And now coming up is the potential role of CSF cytokine profile. Amongst on IL-6 and many others have been studied, and it has been found that they have been useful in diagnosis of meningitis. Imaging, though it is recommended for all patients who have suspected ventriculitis meningitis, it is more for exclusion of other diagnoses or other pathologies or complications of meningitis like abscesses. And the preferred mode is of course MRI, and where what you can demonstrate on the MRI is ependymal enhancement on the T1 scan, and diffusion weighted imaging can show a pus collection or something like that. You need to have a differential diagnosis in mind when you do an imaging like CNS lymphomas, ependymal spread of glioma, metastasis, and etc. Apart from that, USG of the chest or the abdomen or CT of the abdomen to look for in wherever you have a ventricular peritoneal shunt to detect CSF loculations at the shunt terminus can be done. Now, once you have made a diagnosis or you have a suspicion of meningitis or ventriculitis, what should be your empirical antibiotic choice? And then the first is that whenever you think about empirical antibiotic choice, you need to look at where is the site of infection. So in this case, it is of course the brain, the ventricles, or the CSF or the lumbar site, and the other thing is your flora. So what is the site of your infection, what is the flora, and what is the prevalent organism in your hospital and in ICU. So usually if we look at the Indian ICUs or overall scenario across the world, it is the gram-negative bacteria which have been prevalent nowadays in all the ICUs and even in nosocomial meningitis or ventriculitis. And the Acinetobacter is the most common one, followed by Staphylococcus aureus and Pseudomonas aeruginosa and the coagulous negative Staphylococcus. And the Klebsiella pneumonia is fastly catching up. It is coming up as a major pathogen. And this is a data from this particular survey or a study, a cohort study, wherein you can see that the Acinetobacter baumannii is the predominant organism, 15% followed by Pseudomonas and rest of them. And apart from that, Staphylococcus aureus being a skin organism. Then whenever you choose an antibiotic, as I said, because you have to look at what is your flora and what organisms you want to cover. So in this case, ventriculitis, you would want to cover a staph, you would want to cover a Pseudomonas and Acinetobacter. So the drug of choice usually becomes, when you start an empirical, you start with an vancomycin. For a gram-positive coverage, you start with meropenem or a third-generation cephalosporin. Usually, they would be resistant, and sometimes they would be even carbapenem resistant. So you don't have a choice but to start with colistin or polymyxin, which you are comfortable with. You have to use the PK/PD properties of antibiotics whenever you're giving them. Sometimes giving them as an infusion helps to maintain a good sustained level. The drugs which are hydrophilic and have a good penetration in CSF, that is what has to be chosen. When you have an anaphylaxis to beta-lactam antibiotics or meropenem is contraindicated, then aztreonam and ciprofloxacin are the alternatives. This, once you get the culture report and once you have a specific organism which you want to treat, these are the list of organisms, predominantly gram-negatives, and the drugs. We need to know what are the drugs which are good, which have a good penetration in CSF, and some of them to name are vancomycin, penicillin G, daptomycin, Septran, cephalosporins third generation, that is ceftriaxone and cefepime, ceftazidime. Among carbapenems, meropenem, alternative are astronams and ciprofloxacin. Then polymyxins, and if it's a fungal, amphotericin, voriconazole for fungal infections, and if it is a fungal infection, as I said, voriconazole and amphotericin. What is important to know is when you are choosing the antibiotic and giving, is look at this part, that the drug levels have to be achieved in the CSF. So usually what routinely you use, the dosage has to be doubled or has to be given 1.5 times when you are treating a CNS infection, because the drug levels are not very great in the CSF. What is the role? Is there a role of, apart from IV therapy, is there a role for intraventricular antimicrobial therapy? Or in which patients you would use intraventricular antimicrobial therapy? Patients who have a poor clinical response. What is a poor clinical response? It is when the patient is not responding or not getting a clinical response despite of 5 to 7 days of IV antibiotics. And that is usually the ideal time, but now the spectrum is coming towards early use of intraventricular antibiotic, especially if you have an indwelling catheter. Then other patients are infections or patients who have an extensively drug-resistant organism like carbapenem resistance Acinetobacter, or a carbapenem resistant Pseudomonas aeruginosa, or a carbapenem resistant Klebsiella pneumoniae. Patients who have an implanted devices or drain which cannot be removed, and more in cases of ventriculitis versus if it is only meningitis. How can you give the intraventricular or intrathecal antibiotics? The routes are usually by giving lumbar puncture. You'll have to do repeated lumbar puncture or put a lumbar drain or do a ventriculostomy. We prefer an external ventricular drain with Ommaya chamber, and this is a routine practice to put in EVD with a Ommaya chamber. The Ommaya chamber has an advantage that you don't have to, it can be tunneled into the under the scalp, and you can give antibiotics as well as collect the sample if you want to monitor the trough levels, as well as send it for serial monitoring if you are getting a response to your therapy. The preferred one is intraventricular, of course, as compared to lumbar, because it gives an even distribution of the drug, and it also bypasses any blockages to flow distally. Early versus late, as I said, now the shift is towards using it early. And it has also been showed that CSF sterility and normalization of CSF parameters were achieved sooner with intraventricular and intravenous antibodies when they were used as combined versus when intravenous antibiotic was used alone. Minimum installation duration was for 2 to 3 days after CSF sterility, and the average duration that you would give these intraventricular antibiotics is usually around 10 to 14 days, or if you are not getting a response till the last culture is positive, you can extend it up to even for more than 3 weeks as well. We talked about these drugs which are usually okay for CSF penetrations or good for CSF penetrations. Continuing with the role of intraventricular antimicrobial therapy, the idea is to achieve 10 to 20 times concentration of antimicrobial as compared to their MIC. So if your MIC is 10, you would want to have achieve a concentration of maybe 70 to 80, or if your MIC is 6 of a drug, the achieved concentration should be around 60 of serum to achieve a concentration into the CS, a good concentration serum. After giving the drug, you must clamp the drain for around 15 to 60 minutes. 15 to 20 minutes is the usual practice. If you have a large volume CSF or ventricle, then you will have to clamp it for 1 hour, or the drainage. Penicillins and cephalosporins should not be given by intrathecal route or intraventricular route because they have associated neurotoxicity, especially seizures. And the trough CSM concentration, there is something called as inhibitory quotient, which is the ratio of the trough CSF concentration to the MIC of the agent, and it has to be maintained at about 10 to 20, the inhibitory quotient what I talked about. The primary concern with the intraventricular installation of antibiotics is development of chemical meningitis and sometimes seizures, because these antibiotics do contain preservatives. The antibiotic doses also have to be adjusted as per the ventricular size and the volume. as well as how much is the CSF drainage. So if you have a slit ventricle, then the dose would be maybe, for example, if you take vancomycin, it is 5 for 5 milligram. For normal side, it should be 10 milligram. But for enlarged ventricle, you will have to increase the dose to 15 to 20 milligram. Similarly, if the drainage of CSF is happening, if the drainage is less than 50, then every third day dose is good enough. If in 24 hours CSF drainage. If it increases to 100, then every second day. If it increases to 150 once daily, and more than that, maybe you will have to increase the dose of the drug as well, and accordingly. In children, you have to decrease the dose by 60% because the CSF volume is less. These are some of the drug and their recommended doses for intraventricular administration: amikacin, colistin, amphotericin, daptomycin, gentamicin, polymyxin, tobramycin, vancomycin, vincristine, dantrolene. Apart from these drugs, tigecycline is one drug which can be given as well. Now, infection caused by, how do we optimize the optimal duration for treatment is around 10 to 14 days for Staphylococcus aureus infection as well as gram-negative bacilli. Sometimes for resistant organism, you have to increase the duration to 21 days, or if your CSF is not becoming negative, even after 14 days of antibiotic, or the cultures are persistently positive, or the patient is not responding, then you have to continue the therapy for 10 to 14 days after the last culture was positive, especially in MDR works. For Candida and for Aspergillus, we talked about amphotericin plus or flucytosine cytosine combination plus voriconazole plus minus voriconazole, depending what fungus you have. For Aspergillus, it would be voriconazole plus minus amphotericin. There is no role for dexamethasone or hypothermia. Whether we should remove the catheter and reimplant it? Yes, wherever there is a source of infection, suppose you have put in an EVD and then you developed a ventriculitis, the catheter has to be removed. Before that, you send a CSF for examination. You can install some antibiotic and then remove the catheter. Usually around 5 to 7 days, the colonization would happen, and up from 7 days to around 14 days to 3 weeks, the biofilm would be amenable to antibiotics penetration, and you can still keep the catheter, or you remove the catheter and put another fresh one to install the antibiotics intraventricularly. But the dictum is, whenever the source can be removed, you should remove it. Whether you can reimplant the catheter, if after the treatment of after the treatment of ventriculitis and meningitis and the culture is negative, for Staph aureus or gram-negative organism, gram-negative bacteremia or meningitis, after 10 days of CSF culture negative antibiotic, you can reimplant the device if it is required. Now, coming to the prevention, that is the last part of my talk. The best approaches and what you should do. Periprocedural prophylactic antibiotic administration is recommended for patients undergoing CSF shunt or drainage, and it should be given for 24 to 48 hours. That it has shown to decrease the chance of infection by 50%. However, for the duration of the external drain, for example, if you are keeping the EVD for 7 days or a shunt for 10 days or 15 days, prolonged antibiotics is not recommended. It doesn't have any benefits. In fact, it would increase the chance of infection with a resistant bacteria. Prophylactic catheter exchanges after every 5 to 7 days is not recommended. You can keep it for as many days as you want. Use of antibiotic impregnable CSF shunts and CSF drains are coming up in a big way now. It is recommended and it is being showing benefits. Antibiotic impregnation is usually with rifampicin, minocycline, and clindamycin, and there are some silver impregnated catheter also, as we have for central lines. Standardizing protocols following and bundle care following and strict adherence to it is of utmost importance whenever you are handling the catheter, during the procedure, when the nurses are handling, they should be trained nurses. A good aseptic precaution has to be followed whenever you are giving or draining or whatever you are doing with the catheter. The other thing is, you can tunnel the catheter more than 5 centimeters away from the borehole. That will prevent infection. For neurosurgical patients, perioperative antimicrobial agents are recommended, as we said. In patients with basilar skull fracture and CSF leak, however, prophylactic antibiotics is not recommended. In fact, in patients with basilar skull fracture and a prolonged CSF leak of more than 7 days, it is better to repair and fix the problem rather than giving antibiotics. Giving antibiotics doesn't prevent infection here. In fact, it might predispose the patient for having multi-drug resistant organism. However, In patients with basilar skull fracture and CSF leak, you can go for a pneumococcal vaccination to prevent infection. Thank you. Be kind to your brain.
Thank you, Dr. Ravi. Thank you. It's a fantastic job you have done. You are covered in small time, but definitely it's a huge help to all the neurosurgeons all over the Maharashtra. I should suggest that definitely we should be having one talk every year about the meningitis and ventriculitis. Now we will come to our next talk, that is about the management update of subarachnoid hemorrhage by Dr. Sushant Admani. And I would request him that he should finish off in time. Dr. Sushant is actually intensivist in neuron. Neuron, as it's my baby, it's really catering almost 30 to 40 cases in 2-3 months of this winter session, and almost 60 cases per year, 60-65 cases of subarachnoid hemorrhage a year. So let's see how he is managing this with the update.
बाहर जा
Good evening, everybody. Myself, Dr. Sushant Atmane, Chief Intensivist and Clinical Director working at Neuron Hospital. So I will be speaking on management of subarachnoid hemorrhage clinical update, which is based on AHN ASIC guidelines of 2023. Now, in short about subarachnoid hemorrhage, the prevalence is estimated around 10 to 11 cases per 11 lakh. The most common cause of subarachnoid hemorrhage is trauma, but non-traumatic subarachnoid hemorrhage, 85% are due to ruptured cerebral aneurysm. In about 20% of cases, cause cannot be ascertained. The benign perimesocapillary subarachnoid hemorrhage constitutes less than 10% of cases. Now, this diagram shows the prevalence of aneurysm in the circle of Willis. You can see from here, the anterior cerebral artery aneurysm constitutes around 40% of prevalence. Middle cerebral artery constitutes 34% of prevalence, and basilar top some posterior circulations constitute around 4%. So, most common site of aneurysm in circle of Willis is usually the anterior cerebral circulation. So, in our center at Neuron Hospital, we have treated approximately around 350 to 400 cases in the last 5 years, and around we found 50% were angionegative, and around 25 to 30% had dilated cerebral ischemia, and 18 to 20% had hydrocephalus. So, I will be covering this topic as where to manage this type of patient, whom to be screened for subarachnoid hemorrhage, what investigation should be done to diagnose the patient, and how should we manage the subarachnoid hemorrhage, and what are the complications of subarachnoid hemorrhage. Now, coming to where to manage patient. So, subarachnoid hemorrhage patient should be managed in high volume center, which has got a dedicated team of neurosurgeons, neuroanesthetists, neurointensivists, neurologists, and neurointensive care nurses. And what do you mean by high volume center? It's usually definition, as per definition, it's the hospital which treats at least or gets more than 35 cases in a year. So management in center has shown that there is a reduced mortality and increases the likelihood of good outcome. So if low volume center gets a patient of subarachnoid hemorrhage, they should preferably transfer patient to high volume center to increase the good functional outcome and decrease the mortality. So now whom to be screened actually? Now this is something interesting which has been mentioned, which has not been mentioned in 2012 guideline. It is a Ottawa subarachnoid hemorrhage. It serves as a screening method to detect patient with low likelihood subarachnoid hemorrhage and who are unlikely to have subarachnoid hemorrhage. It is 100% sensitive. And what does it tell? See, our previous teaching was that patient who was how we used to diagnose the patient, how we used to suspect patient subarachnoid hemorrhage. It usually used to do definition went like that. The patient is having maximum intensity of headache, or patient is having thunderclap headache, or headache which is worst in life. So now they have got a more structured definition. Now it suggests that any new severe non-traumatic headache which is reaching maximum intensity within 1 hour should undergo investigation. And what are the additional investigation which we should look for to suspect a patient have subacute hemorrhage are age more than 40 years, patient is in neck pain or stiffness, who has witnessed loss of consciousness, who has onset during exertion, who has a thunderclap, a headache which is instantly peaking, and limited neck flexion or examination. So the main investigation, which is the cornerstone of subacute hemorrhage, is the plain non-CT contrast. Actually, it has got a sensitivity of more than 90% to 100%, 90 to 95%. So when patient presents the acute severe headache, you should try to apply Ottawa subacute hemorrhage rule, and a non-contrast CT should be done. And what should we look for on a non-contrast CT? Preferably, we should look for a bleeding on basal systems and bleeding in the screen fissure. Even the CT findings can help in the site of location of aneurysm. So if patient is found to have a positive finding on CT scan, that patient should be referred for a CT angiography or DSA. CT angiography is more sensitive than a non-contrast CT. So CT angiography helps to pick up the type of aneurysm, its location, and but problem, the pitfall of CT angiography is that it cannot pick up small aneurysm which is less than 3 mm. So even if patient is having CT angiography negative and suspect a subacute hemorrhage, then there is another test which is called a suppression angiography, which has got a high sensitivity, and it even picks up the small aneurysm which is lesser than 3 mm of size. So now this flowchart tells the patient present with more than 6 hours of neurodeficit in non-contrast CT shows a negative finding on CT, and you don't get a hemorrhage, and you suspect a subacute hemorrhage, and patient should be subjected to lumbar puncture, and you should look for a xanthochromia. Why more than 6 hours? Because xanthochromia occurs late, and xanthochromia should be evaluated by spectrometry analysis, not by visual analysis, because the early xanthochromia by visual analysis can be missed in hyperacute phase. So specifically, xanthochromia should be done by spectrometry analysis to enhance the sensitivity. So, as I mentioned earlier, patterns which on CT are likely to reflect the presence of underlying aneurysm or diffuse basal system, civilian fissure, hemorrhage, and CT angiography should be next diagnostic performed when subacute hemorrhage is diagnosed non-contrast CT. And DSA is the gold standard. If you suspect CT angiography is negative and patient is having a strong, you suspect a strong suspicion of subacute hemorrhage, DSA should be done. So now, how should we manage a subacute hemorrhage? Now the guidelines say the guidelines say the aneurysm augmentation should be done as early as possible, preferably within 24 hours. Why? Because it reduces the risk of bleeding. Now there are two main options to secure aneurysm. One is endoscopic coiling and one is surgical clipping. So 2012 and 2023 guidelines, they mentioned they agree on the same thing for anterior circulation and posterior circulation aneurysm. If it is equally suitable for primary coiling and clipping, then primary coiling is recommended in both the cases. Now we'll do the clipping stance. Clipping has age in cases like patient is less than 40 years with subacute hemorrhage, and patient is having a hematoma, is undergoing evacuation, say more than 50 ml for mass effect, and patient is having ruptured MC aneurysm and anterior circulation bifurcation aneurysm. In less than 40 years with subacute hemorrhage, it has shown it protects from the rupture which is related to coiling. So it should be preferred in less than 40 years. Now with advances in intervention radiology, various stent-assisted coiling and flow diverters are there, and when they should be preferred, they should be preferred in ruptured fusiform distal aneurysm, because distal aneurysm itself is difficult to coil, and more complex surgery like wrapping is required, carries a morbidity, and subacute hemorrhage from wide neck aneurysm which are not amenable to surgical coiling and clipping should be managed by either stent-assisted coiling or flow diverter. But for sacral aneurysm, it should be either treated by primary coiling or clipping. Stent flow or diverter should not be used as it carries a high risk of complication. So if for due to some technical difficulties, complete obliteration is not possible, then you should always try for a partial obliteration to secure the rupture site, as it can reduce the whatever the risk of the rebleeding, and retreatment should be done in a delayed fashion whenever the functional recovery and the thesis of the patient allows. So now how should we manage the blood pressure in subarachnoid hemorrhage? Now there has been change in the guideline as compared to 2012. So previous guideline used to suggest that we should keep a systolic BP less than 160, but now available evidence is not recommending a specific BP target, but they still say if patient is having blood pressure more than 180 to between 180 to 200, it should be brought down gradually by the use of short-acting and antihypertension. There should be complete avoidance of hypotension, and there should be minimum BP variability, because BP variability is associated with the worst outcome. So, and your target for BP reduction should be individualized and it should be titrated according to the patient profile. So sometimes we can target higher BP in patient who may require a higher BP for his to maintain a better cerebral perfusion, and such type of patient are who presented with history of hydrocephalus, who has history of hypertension, and who has history of renal impairment, because their autoligation curve of BP shifted to a right side. So we may target a blood pressure on a higher side, say up to 170 to 118, such type of patient. So we should avoid increased BP variability, as it has been shown with worse outcome. There should be always a gradual reduction of BP when patient is severe hypertensive more than 180 to 120. And now there has been change in the recommendation. Now previously 2012 guideline, they recommended the use of antifibrinotic, which was awarded the recommendation of grade 2 moderate evidence. But now antifibrinotics for the prevention of bleeding are not recommended. Now coming to the complication of subarachnoid hemorrhage. Complications of subarachnoid hemorrhage can be divided into two parts. One is surgical and other is medical. So most common surgical complication which we encounter in ICU is delayed cerebral ischemia and vasospasm. Now various theories have been suggested why this vasospasm occurs. It occurs because of microthrombosis. It occurs because of inflammation, and it can occur because of the blood-brain barrier disruption. So usually symptomatic vasospasm occurs in 20 to 30 percent of patients with subarachnoid hemorrhage. Onset is usually seen at around 4th to 5th day, and it usually resolves by 12 to 15 days. It directly correlates with the underage grade and an amount of blood seen in the CT scan. So more the blood, more the higher grade of underage classification, more is the likely possibility the patient can land up into vasospasm. So how to diagnose vasospasm? Clinically, it is diagnosed by a patient is having neurological deficit like paresis, aphasia, decreased level of consciousness. Simultaneously, we note the other causes of deterioration like rebleeding and hydrocephalus, cerebral edema, seizures, hyponatremia, hypoxia, and sepsis. Now, how it can be diagnosed? It can be diagnosed by various investigation. First is transcranial Doppler, other investigation CT angiography and CT perfusion. Transcranial Doppler is simple non-invasive bedside test to detect vasospasm. It works on the principle that as there is a vasospasm, there is a narrow in the caliber of the diameter and the blood flow velocity increases. So vasospasm is usually defined as a mean cerebral blood flow velocity of more than 120, and we look for a Lindegrad ratio. What is Lindegrad ratio? It's a ratio of velocity of blood in MCA to velocity of blood in ICA. So there is a pitfall of transcranial Doppler. It is that it is less reliable in detecting vasospasm in anterior cerebral artery branches and posterior circulation arteries. Simultaneously, it is operator dependent, and sometimes we cannot get an operative window if there is a dressing, and it can hamper your view. So when using transcranial Doppler to monitor cerebral vasospasm, it must be always interpret the clinical correlation. The other diagnostic tests include CT angiography and CT perfusion. CT angiography almost has a sensitivity of 2 to 95 to 90% for detecting vasospasm, and CT perfusion it can identify patient as early as 30 who is at the risk of entering into a vasospasm window. The other diagnostic which are used to predict degree cerebral ischemia are continuous EEG monitoring, invasive monitoring of brain tissue, oxygen, lactate pyruvate ratio, and glutamate, which are usually preferred in high-grade SAH. So there is interesting continuous EEG monitoring features which can be suggestive of delayed cerebral ischemia. They are decreased alpha ratio, alpha to delta ratio. There is decreased alpha suppression, and there can be some epileptic discharges form. So this can be such a delayed cerebral ischemia. So this is a picture which depicts how does a vasospasm appears on CT angio and angiography. So first picture, it shows a echomechanism. Now it has slide B shows a clipping of aneurysm, and it has been shown it has been follow and it follows we can see the narrowing of ACA. You can compare the caliber on the counterlateral side, shows clearly shows that it is in caliber. Now same thing, it has been confirmed on PSA, which shows the vasospasm involving A1 segment of anterocerebral artery. So how to prevent and how to treat delayed cerebral ischemia and vasospasm? Till now, only therapeutic evidence with class 1 evidence for decreasing subarachnoid hemorrhage to vasospasm is nimodipine. And recommendations say nimodipine should be started with 96 hours of initial hemorrhage and should be continued for 60 mg every 4 hours for 21 days. It should be started as early as possible. Suppose if your oral nimodipine cannot be started, then you should start IV nimodipine as early as possible. But there can be adverse effect of hypotension with starting of IV nimodipine, but it's recommended since the benefit is more, even if there is a slight hypotension, you can start with, you can continue the nimodipine and start on patient should start on inotropic support. Now, intravascular hypovolemia is associated with delayed cerebral ischemia and shows a unfavorable neurological outcome, so it should be always avoided. So current guidelines, they recommend avoiding hypovolemia and maintaining intravascular euvolemia and aneurysmal subarachnoid hemorrhage. Prophylactic use of triple H therapy is not recommended as it is a worst outcome and fluid overload in patient with subarachnoid hemorrhage with euvolemia and patient develops symptomatic vasospasm. Then you should always target for hypertensive therapy and try to elevate the systolic blood pressure, preferably with NORAD. In patient, in spite of all, patient is having euvolemia, you did a hypertension therapy, but still patient has got a refractory vasospasm, then you should go for a cerebral angioplasty with or without spasmolytics in form of intraarterial calcium channel blocker and nimodipine and verapamil, and they should be always used for to reverse the cerebral vasospasm in refractory cases. Statin magnesium is not recommended to reduce the delayed cerebral ischemia or improve the functional outcome in subarachnoid hemorrhage. Now this is the flow chart which which shows how to approach a patient with cerebral vasospasm after subarachnoid hemorrhage. So we should always start with oral nimodipine, and you should do a regular neurologic examination, and you should always, if patient on neurological exam show deterioration, you have suspicion of delayed cerebral ischemia, you should consider transcranial doctor and should be always combined with invasive multimodal neuromonitoring. Recommendation of multimodal neuromonitoring was not mentioned in 2012. Now it has been mentioned in 2023 guideline, which consists of partial brain tissue oxygen monitoring and continuous EEG and lactate to pyruvate ratio. And you should always avoid prophylactic hemodynamic augmentation. Even after this patient show neurological worsening, you should try to elevate his BP and ensure euvolemia. Even after this patient shows a worsening, then you should go for endovascular rescue therapy with spasmolytic and angioplasty. Now, patient care seizures. Now there has been change in the recommendation. Previous recommendation said moderate recommendation to administer anticonvulsant to patient to have a subarachnoid hemorrhage. Now prophylactic use of anticonvulsant after subarachnoid hemorrhage is not recommended, but still prophylactic anticonvulsant should be used in high risk patient like presence of MCNS, high clinical and radiological grade like underage grade more than 3, Fisher grade more than 3 to 4, cortical infarction or hydrocephalus. Anticonvulsant of choice is levetiracetam over eptoin because eptoin has been eptoin shows greater incidence of adverse effect, and second thing, it has associated with cognitive dysfunction. And how long it should be continued? It should not be continued more than beyond 7 days. The other surgical complication, hydrocephalus, around 20% develop 20% of patients develop hydrocephalus. It correlates with the amount of blood on CT scan and underage severity. CSF diversion either by EVD or lumbar drainage should be performed to improve neurological outcome. Chronic hydrocephalus may need revision. Now coming to the medical complication, cardiac dysfunction. So about this occurs in about 30% of patients having subneurocranial hemorrhage. Subneurocranial hemorrhage itself can cause STT changes, TV invasion on ECG, urogenic myocardial turning or stress cardiomyopathy is seen. Seizures and subneurocranial hemorrhage can lead to neurogenic pulmonary edema. Now coming to another medical complication, that is hyponatremia. It's the most common erectile dysfunction after subneurocranial hemorrhage. Two most common causes of this hyponatremia is cerebral salt wasting and SIDH. Now, when there is a hyponatremia, you must differentiate between what is the cause of cerebral salt wasting and SIDH, because treatment of both etiologies are different. Cerebral salt wasting syndrome is a hypovolemic state, and SIDH is a euvolemic or slightly hypovolemic state. So, cerebral salt wasting syndrome will require a fluid, but SIDH will require, if patient is drowsy, will require a hypertonic saline therapy. The routine fluid restriction which we practice in SIDH should not be done because it can induce vasospasm. So it should be clearly differentiated what is the cause of hyponatremia and subarachnoid hemorrhage. Another complication which occurs in subarachnoid hemorrhage is fever. Up to 70% develop fever during the clinical course. Fever can be because of infectious or non-infectious cause. Fever is usually associated with higher subarachnoid hemorrhage clinical grade, and it's usually effective to antipyretics. And we should try to manage with surface cooling or endoscopy technique. DVT occurs in subarachnoid hemorrhage patient. Measures to prevent DVT should be employed in all patients with subarachnoid hemorrhage. Mechanical prophylaxis should be started on admission itself, and the use of low mercury heparin for prophylaxis could be started 24 hours after undergoing aneurysm augmentation, after confirming with the intervention radiologist or the operating neurosurgeon. Hyperglycemia is another risk factor which shows a poor outcome and hence be directly correlated with the risk of vasospasm. Hypoglycemia should be avoided, and we should always try to maintain blood glucose between 140 to 180. So I would like to end my talk on this note. Aneurysmal subarachnoid hemorrhage is a neurological emergency associated with significant non-neurological complication. We should always consider to transfer patient to expert center with sufficient volume of aneurysm cases to improve the outcome. After rapid stabilization, early definite treatment by neurosurgical clipping or endovascular coiling is required. The early care of patient should focus on limiting secondary brain injury. Thank you. I think I'm on time.
Thank you, Sushant. So it's such a small brief by Dr. Sushant regarding the update in management of the subarachnoid hemorrhage. Right now, we will take questions and opinions from the expert panelists. I would request Dr. Kishore Chaudhary to start with the opinion on subarachnoid hemorrhage first.
Well, I think, can you hear me?
Yeah, sir.
I think, Sushant, that's an excellent summary of subarachnoid hemorrhage management in the ICU. I was thinking of what to say, that what did you exclude, but I think it's not only excellent, but it's very comprehensive as well. And I can't think of anything that you have excluded. What we do in our center, we got a huge number of subarachnoid hemorrhage, 200 patients per year. And we are only 2 surgeons who manage them. But we have a very strong ICU HDU team. We got a backup of the radiologists, nurses, expert nurses, and a lot of junior doctors. What we don't do is we do not do transcranial Doppler on a regular basis. One of the reasons for that is we don't have enough manpower to do that all the time. And we also don't do regular angioplasties or interventions for vasospasms. And the reason for that is sometimes most of the times their results are short lasting. And if you treat the vasospasm medically, most of the times you can get over the complications if given sufficient time and if you take care of other things. I wasn't sure about the Ottawa scale that you said, the Ottawa guidelines. We all do that, the investigations, but I didn't know that it was called Ottawa. I don't think Ottawa themselves have that large number of subarachnoid hemorrhage patients. But anyway, that's a different thing. We otherwise do everything that what you have pointed out, and I think it's a very good review for people who don't treat aneurysmal subarachnoid hemorrhage that often. I think whatever Sushant has said in the guidelines I think those who treat them occasionally or less than very frequently, I think if you just follow the guidelines that Sushant has outlined, I think you will do a lot of good for the patients. So really congratulations for your excellent overview of such a complex topic in a very comprehensive manner.
Thank you, sir. Thank you.
So the next, rather, I would say that some few suggestions from Nikhil sir about the ventriculitis and meningitis talk. Sir, you are mute. Dr. Nikhil Palanke sir, you are mute.
Yes, yes.
Yeah.
Sorry. And congratulations, Pramod, to you, to your team for covering such a interesting and important neurocritical care topics in such a small time. I should congratulate all the three speakers, Madam, Sushant, Ravindra, for lucid, comprehensive coverage to everything. Regarding the ventriculitis, we all know how difficult it is to diagnose, and once you diagnose, how it is difficult to convince the patient for the duration of therapy and the antibiotics. Ravindra has covered them all. My only concern is, like he said, that sometimes the intrathecal or intraventricular antibiotics are considered after 5 to 7 days of the treatment when the patient is not responding to the conventional therapy. My question was, how if the patient is sick enough and too critically ill, and we know the ventriculitis is severe, why not start it simultaneously? So one is whether should we start it more earlier than 5 to 7 days. Second is, if you have a shunt inside, he said we remove the shunt and reinsert again. So is it going to make a change, or should we just remove it and keep it like that for some days? So Ravindra is a better person, or even you people who are doing it day in and day out are better people to answer this question. But it was a very academically satisfying feast in the evening today. Thank you for that.
Thank you, sir. Thank you. There is a Dr. Karapurka sir has just joined. Yeah, Ravi, you want to say something? Yeah, definitely.
Yeah, means if I have to answer his question, the first question was whether we can give early antibiotics intraventricularly. So the usual dictum and whatever studies have been done and people have put in guidelines is that the standard of practice is that ideal time to give intraventricular antibiotics is after 5 to 7 days when the patient is not responding. But at the same time, people are moving towards early intraventricular antibiotics nowadays with resistant drug developing. So if you are talking about a multi-drug resistant bacteria, something like Acinetobacter, which is carbapenem resistance, yes, there is a role for early antibiotics. In our center, we prefer to give it early whenever, early diagnosis and early intraventricular institution has definitely a role, and it of course differs center to center and your expertise in what you have.
Thank you, Ravi.
Thank you.
Sir, good evening. Karapurka sir.
Good evening.
Good evening.
So I've been attending to the whole meeting, and I've heard all the speakers, and I congratulate all the speakers. Of course, I cannot add anything to what Madam Depujari has already said, but I thought for subarachnoid hemorrhage I can add some more practical points for
definitely
those who don't look at subarachnoid hemorrhage patients so frequently. So number one, if the CT scan is done on day 1, the blood will be seen in the subarachnoid spaces. If the CT scan is done on day 4, sometimes the CT scan will be normal. Clinically, it is subarachnoid hemorrhage, but the CT is normal. So in such patients, an LP should be done. He did mention LP, but an LP should be done in such patients where clinically we suspect subarachnoid hemorrhage, and the CSF will be xanthochromia. So sometimes you have to spin the CSF to see the xanthochromia. So that's one point that I wanted to say. The second was headache. Headache in subarachnoid hemorrhage can be very difficult. And sometimes it doesn't respond to any analgesic that you give. It doesn't respond to mannitol, it doesn't respond to tramadol, it doesn't respond to IV paracetamol. We have found sometimes lumbar puncture is the best. You do one lumbar puncture and the pain is gone. And some of these patients are miserable with the subarachnoid. They keep tossing, turning, they've got severe headache, and this headache, surprisingly, is not continuous. It waxes and wanes. For some hours it is very bad, then it's suddenly gone, comes back again. That's number 2 that I wanted to say. Number 3 was in CT scan, they say that we have got the Fisher classification. Grade 1, grade 2, grade 3, grade 4. Grade 1 is mild subarachnoid hemorrhage, grade 2 is more extensive, grade 3 is with ICH, grade 4 is with IVH. We believe that when there is more blood, the spasm is more likely, but not necessarily. I have seen spasm with minimal subarachnoid hemorrhage. I have seen no spasm with thick clots in the subarachnoid space. So spasm is something that we do not understand. No matter what one says, we do not understand. So one should just anticipate that spasm will occur and treat with nimodipine. Now I must tell you also that nimodipine IV is not available in Europe. It is available to us. And in Europe, it is not available in US. It is available in Europe. So many of the publications in the US will not talk about parenteral nimodipine. Whereas in Europe, in UK, Kishore can bear me out. And for us, it is available as a parenteral injection. So today, in addition to nimodipine, milnirone is found to be very effective. So more and more, we have switched to milnirone. So milnirone can be given as an oral preparation. It can be given as IV. It can be given as intraarterial. And more, earlier we used to give IV nimodipine. Now, very few people give IV nimodipine because managing the blood pressure is a big hassle. Whereas with milnirone, it is much easier. The problem with milnirone is the management of the heart. If you give it too rapidly, these patients have cardiac problems. But milnirone is, in fact, very effective. So even when we do intra-arterial angioplasty with chemical angioplasty, we use both. We use 1 milligram of nimodipine and we use milnirone intra-arterial. And Kishore said they are not very happy with it because it needs to be repeated. That is true. Sometimes we may need to repeat it. So clinically, we monitor these patients, and if it is required, we take the patient back and inject again. And I have not done it myself, but there are at least 2 places in India where they leave a catheter inside the artery, ICA, generally in the ICA, and infuse nimodipine continuously for 48 hours, 72 hours. And once the patient has started to come out of the spasm, then take the catheter out. And they have shown excellent results with this. And they have reported this also. So intra-arterial nimodipine with milnirone is very effective in spasm.
Thank you, sir. Thank you.
Can I ask you, all of you, a question about using noradrenaline versus metreminol for maintaining adequate blood pressure in case the blood pressure fall? We usually use metreminol very regularly because I think it obviates the need for a central line. Is that correct? But I had never, none of the speakers I heard mentioning that. So I just wanted to know in India whether what is the method of maintaining blood pressure, the best way of maintaining blood pressure.
So
but I don't know what the others have been using.
We are routinely using noradrenaline with the arterial line, but not metronidazole also.
Oh, milnirone is very effective actually.
Yeah. Now we'll try for the next cases. Definitely the lesson learned today for management of the vasospasm. Sir, it is really troublesome when you are going to give a very good result by doing the surgery, and after that losing a patient for severe vasospasm. It's really nasty for the surgeon.
Patients who have come in on day 4, very good. Day 9, spasm on one side. They get spasm on the other side, and sometimes it is not common. It just progresses, and we've lost 3 or 4 patients because despite everything that we have done, the patients have succumbed. Luckily, there are very few, but there are instances where the patients have succumbed to spasm.
Sir, thank you, sir. Thank you, all the speakers. I think that Dr. Oak is not there. I think this concludes the today's webinar about all the 3 important neurocritical care managements. I again thank you, Dr. Ashi Madam. She has spared her expert views on the management of the ventilation, airway protection, and the sedation, role of sedation. So hand over to Dr. Milind sir. I think that Dr. Milind. Hello. Milind sir.
Yes, I'm here, sir.
Yeah. Thank you, sir. Yeah, hand over to you.
Yeah, sir. Thank you. Thank you, Dr. Pramod Giri, sir. You have chosen very nice topic and the selection of the speakers, and really it was a feast, academic feast. All the speakers have delivered their speech very nicely, and they were very informative. And all the panelists have discussed most of the problems, and they have given some good suggestions, like Dr. Karapurkar sir has advised about Milleron. And really, it was enjoyable academic feast. And I thank you, Dr. Giri sir, and all the panelists and speakers for giving their precious time and making this webinar more informative and academic. Thank you, and to thank you all the audiences, those who have participated, and definitely I think that they have must be benefited with the all the topics and speakers. Thank you, good and good night, sir. Thank you.
Thank you for
Thank
Thank you,
making me a
Sarah.
part of this.
Thank you.
Thank you.
Yeah. It was a pleasure to be here and know all you and be a part of discussion.
Thank you.
Thank you. Good night.
Thank you.
Sarang, I think that we have already recorded this and we will telecast on the mail. I think that you will be sending the recordings on mail.
Yes, sir. Yes, sir.
It will be available tomorrow.
Yeah. Thank you, Sarang.
Thank you. Thank you, sir. Good night.
Good night.
Good night.